What is up? What is up, everybody? Welcome to another live stream of the Insomniacs live stream here on my YouTube channel. I am your host, Dr. Andrew Kim, MD. I'm a board certified psychiatrist. And thank you for the regular subscribers to my channel. For those of you who typically tune in to watch these live streams on Tuesday and Saturday nights at 10:30 Central, 11:30 Eastern. I know that I went on a hiatus for about a week and a half. My son Tyler, 9-year old, had spring break. So you know what? I took a week of PTO, took some time off to refresh, recuperate, rejuvenate. It was really nice to not work for a week. I know that's a luxury. Not everyone has the benefit of getting PTO at their jobs. So it was a luxury, and I acknowledge it's a luxury and had a good time. Was able to take my son Tyler down to Cancun, Mexico, and spent about 4 nights there. Beach, pool, eating some food, and most importantly, spending time together and not working. And was back at it today and yesterday and today, and reality sets in, and back to the grind. So for those of you who've been grinding, hope you guys are doing well. Hey, D77, thanks for joining. So today's topic, we are going to actually walk through a sample report of GeneSight. GeneSight is one of the companies out there that does genetic testing for profiling your liver enzymes and certain genes, basically genetic testing, to try to give guidance to patients and prescribers about what psychotropic meds to maybe utilize, be cautious of, etc. And let's talk about it from A to Z of what does that process look like? What does it entail? What information can it actually provide and not provide? How much weight and expectation should you put into this if one is to pursue this kind of testing? I'll give you kind of the behind the scenes insight on what I would be thinking as your prescriber, looking at these results. And then you can just kind of weigh in to see, is it even worth it for you as an individual to pursue such testing? And I'm going to try my best to give you a balanced point of view. I am going to poke some holes into some of the results that they give you. I'm also going to give you some anecdotes of how the results in this piece of paper that almost feels like somehow it's like a source of truth can almost become an obstacle and a hindrance to treatment. And again, to be fair and balanced, I'll give you maybe a couple anecdotes where it actually might have made a difference in a case that I've treated before, and let you be the judge and jury about whether you think it's worth it to you or not. So that's what we're going to cover today, and then we'll spend some time in Q&A afterwards. But we're going to walk through an actual sample report. I'm going to put a PDF up on the screen so we can walk through this. A lot of patients have, a lot of viewers, subscribers have emailed me, contacted me saying they keep hearing more and more about this. They've been asking their prescribers about this. And before they invested their hard-earned money, wanted to know what should they expect and what do these results actually look like. So that's what we're going to do. So before we show that sample report, let's just kind of walk through what this testing is about, what it entails, and at the end of the day, what it can really tell and not tell an individual who might pursue this testing. So first of all, what is this concept about genetic testing for psychotropics? Basically, to put it simply, I think this is the biggest misconception, and you'll see the evidence in just a little bit. The biggest misconception is patients believe, and sometimes this is almost how it's marketed to patients, so it's really from this new industry in itself. It's almost marketed as if this will unlock and tell you and your prescriber what exact meds you should be using to treat your ailments and your disorders, and which meds precisely are going to kind of unlock, you know, the cure. And I think that's where there is a fallacy, because what you'll see in just a few minutes, what you will get is some guidance, keywords, guidance on your liver enzymes and how your liver enzymes tend to digest or metabolize these medications. Okay. And it can give you some guidance on whether you might, compared to the average person, metabolize these medications faster, slower, or maybe kind of in the middle, or like an average patient, and maybe give you some general commentaries on use with caution. You might want to dose a little bit lower, slower than usual, more conservatively. You might need to dose more aggressively, use as directed by the package insert. And that is the bulk of what one will receive in these reports. Okay. And there will be some commentary, to be fair. Again, I'm trying to be fair. There will be some commentary about a few keywords, a few different genes and alleles that have been correlated, keywords correlated with maybe being more sensitive to side effects, less sensitive to side effects, maybe some correlation with maybe getting a better response to SSRIs or not. But that's about the extent of one can expect. Now, there will be a couple gene findings where they might say you might, basically have a, genetic expression where you may not, convert, folic acid due to a gene mutation, and you might need extra folic acid supplementation. That might be useful. There are a few concrete things, but the vast majority of the data that you're going to receive is really more about general commentaries about the degree of metabolism that, one may have, with these different psychiatric medications. So at the end of the day, not useless. I also just don't know exactly how useful this is. So I have mixed feelings about that. Now, the next comment I have is, how is this done? Now, how it's done is rather simple. Basically, one has a Q-tip, essentially. You swab the inner part of your cheek, and that's how you get your DNA sample. And they put it in a bag, and they send it off to the lab to analyze. So that part, at least, I will say, very non-invasive, very simple, very straightforward, painless. That part is great, okay? Finally, last part, obviously, and this is very important, is cost and coverage, right? We've come a long way. This came out, over a decade ago. So this is not something novel or brand new. It's finally maybe catching on a bit more in recent years. Back in the day when this was first introduced by numerous companies, right? It's not just GeneSight, but GeneSight's one of the most popular ones. It was rare, if ever, that one could get even partial coverage from their insurance. So people were paying, $400, $500, $600 a pop, because that would be the only way to access this. In this day and age, you will find that some insurances may cover a portion of it. Some might even cover a large majority of the cost. Again, this is me just reading their website. I can't guarantee this, but supposedly, GeneSight's website says they wouldn't expect that anyone would pay more than about $330, $350 out of pocket, is what it says on their website. I can't really tell you how accurate or not accurate that is. So for those of you who are here listening, there are some people on the live stream right now. If you've ever done GeneSight testing or some comparable company or competitor to GeneSight, like GenoMind, or I can't remember all the different names, what was the cost? Have you guys ever had insurance cover some of that, or did you have to fully pay out of pocket, or what was the cost? So I'd be interested to hear your own experiences. But even in present time, in my recent experiences, I don't really order these a lot. I will say I don't actually order them a lot. My experience has been usually insurance doesn't cover the entire cost. And typically the patient has some semblance of out of pocket costs, which has been variable. I've seen some patients have to pay $50 to $100 out of pocket. I've seen some patients have to pay closer to $200, $300. So I've kind of seen the spectrum and a wide variety of variance in how much insurance will or won't cover it. And again, that's predicated that if you have insurance, right? Or if you have decent insurance, right? So let's be very real about that. Um, so Dennis asked the question, could pharmacogenetic testing generate placebo and nocebo responses? Yes, I absolutely believe that. Now, to be clear, that's my personal opinion, but we'll get into that in just a few minutes. But yes, and that's what I meant by there can be a mixed bag, but I think that mixed bag cuts both ways, Dennis. That I think with the power of suggestion and a piece of paper that seems very scientific, one probably could even enhance a placebo effect. And I don't necessarily see that as a bad thing per se at the end of the day, if that leads to resolution of improved response of depression, anxiety. Now, one might criticize my statement there and say, well, is that really going to benefit that patient in the long run? Because placebo responses oftentimes aren't always, a long-term durable solution. Yeah, no, fair criticism. But in some cases, when one needs to improve and get out of a sticky situation when their symptoms are bad, short term, it is what it is. I mean, if that helps you get better and that gives you more faith in your treatment and enhances maybe a genuine partial response, a marginal modest response, and enhances that, then so be it, right? But to your point, Dennis, I also think the opposite can occur. And I have seen instances where treatment was actually going fine, yet for some reason, someone wants to pursue this testing, and then suddenly things go sideways and falls apart because now this piece of paper says, hey, you should be using that med with caution. Why did your doctor even put you on this, even though you've been on it safely and effectively for the last 3 years in a row, and then things just suddenly fall apart? So yes, Dennis, I think it can cut both directions. Very interesting, very good question, and we'll talk about that in a little bit. So let's dive into it. Let's look at an actual sample. Again, this is not PHI or some HIPAA violation. This is literally just a sample result that you can find yourself online, but it does the job and essentially shows you what a typical GeneSight test report will look like. To be fair to GeneSight, this one's a little out of date. I've seen some of the newer ones where there's a few more genes that are commented on, but for the most part, this covers, I would say, almost 90% of what you would see even in a 2025 GeneSight report. So let me pull it up through Adobe here. Okay. So here's an example. Obviously, it says patient sample. So this is an example of the results that one would receive after you submitted your Q-tip, swab of your inner cheek that you sent off to the lab. Okay. And we'll focus primarily on the antidepressants since that's what is most commonly prescribed in the United States when it comes to psychotropic meds. We'll skip through some of the other pages that are on benzodiazepines or antipsychotics. So here, right, what I do like, I will say, GeneSight compared to some of their other competitors, it's a very easy to read, aesthetically pleasing, well laid out, color coded, easy to interpret report, even for a layperson, in my opinion. Okay. So first comment here, right? They put it in green, yellow, and red columns. It'll say green, use as directed, meaning desvenlafaxine, vilazodone, or Vibrate. It'll say just use as you would typically do, like, so dose it the way it's typically meant to be dosed in the package inserts, meaning no real alterations. Okay, so at the end of the day, I guess not super helpful. I mean, maybe comforting and maybe reassuring, but the other way to look at that would be, well, great, I did this to just say use it as you would, as anyone would, right? Now, if you look in the middle column, moderate drug interactions. So you see those numbers there, and they have a legend down here. So you can see the numbers 1, 1, 4, 1, 6, 3, 4, 3, 4. So some of these will say serum level may be too high, lower doses, keywords, and you see this sprinkled throughout may. Serum level may be too high, lower doses may be required. Serum level may be too low, higher doses may be required, right? Number 3 indicates difficult to predict dose adjustments due to conflicting variations in metabolism, meaning we don't know what to tell you. Okay, so that one's not so useful. Number 4 means genotype may impact drug mechanism of action and result in reduced efficacy. Okay, interesting. So they're saying we might have information, keywords though, may impact drug mechanism of action and result in reduced efficacy. Number 6 indicates use of this drug may increase risk of side effects. And number 8 indicates FDA label identifies a potential, keyword, potential gene drug interaction for this medication. Okay. So just so that you know what those numbers mean. So yellow column means, hey, there could be some kind of drug interaction with your genetic subtype. So please be aware. And red column means, hey, there is some kind of significant, interaction or significant metabolism concern, which they'll delineate in the following pages. But as you can see, right, the reason that I was meticulously and annoyingly reading may, potential, is the fact that, yes, these are possibilities. There may be a concern. You may need to lower the dose. You may want to increase the dose. You might be at risk of higher sensitivity. You might potentially not respond as well. Potentially, right? So this is how companies like this cover themselves and get away with not being correct. Right? So may, potentially, could, should, blah, 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 blah. Right? So just bear that in mind as we progress in this conversation. Okay. So for the sake of efficiency, you're going to find similar pages here. So I'm not going to redo what we just did, but they'll give you thorough, like they'll go through different categories of psych meds, like anxiolytics, or what they're really saying is benzodiazepines, and hypnotics like Ambien, Zolpidem, etc. So they'll give you all the Z drugs like Zolpidem, Zaloplan, and they'll give you a list of the different benzodiazepines, in addition to buspirone as well. Similar commentaries in the legend there. They'll also give you, as you can see here, a listing of the different antipsychotics. So they'll cover most categories of meds, of psych meds at least, right? So mood stabilizers. Okay, so let's move on to a different page here. As you can see, like I said, to be fair, right, this is not just about metabolism. There are a few different pharmacodynamic genes that they want to highlight. We'll go through just a couple of them because I think only a couple of them are really worth mentioning. The SLC6A4. So they're saying that if you are homozygous for the short promoter polymorphism of the serotonin transporter gene, there is some evidence that you may have a decreased likelihood of response to selective serotonin reuptake inhibitors due to the presence of this particular expression of this subtype, right? Underneath that, you could see where it says, HTR2A. This individual is homozygous variant for the G allele, and they carry 2 copies of the G allele. This genotype has been associated, keywords again, associated with an increased risk of adverse drug reactions. Now, here's the funny part, has been associated with certain selective serotonin reuptake inhibitors. Not all, but certain ones. So, look, I applaud companies trying to narrow down pharmacodynamic genes and gene interactions with meds. But we have to pause and say to ourselves, how much certainty do we have in the serotonin transporter gene theory and how that correlates with response? I wouldn't say 100%. I would say that might be applicable to a percentage of patients. I know that's a vague statement, but look, for those of you who've been following my channel for a while, you know that I feel very similarly to a lot of these anti-psychiatry sentiments, anti-psychiatry psychiatrists, where we do have a Venn diagram and where I do agree with some of these folks. And I think most sensible psychiatric researchers and psychopharmacologists also agree. We don't think that these anti-psychiatry psychiatrists are that revolutionary in their thinking, is that this whole concept of the monoamine hypothesis of serotonin, norepinephrine, and dopamine being the key to somehow unlocking and treating depression and anxiety is a fallacy, right? And it is an incomplete picture. It may be a fractional portion of the explanation of how mood and anxiety is regulated, and it may only apply to a percentage of patients. For those of you who followed me, you understand that, look, I have worked in clinical research, and right now all of the focus is on GABA and glutamate systems. We're looking at psilocybin and hallucinogens, right? We're looking at all these other different mechanisms, seeing that those have just as much potential, if not maybe even possibly more potential of being beneficial, that this whole serotonin hypothesis is a rather incomplete and maybe just a fractional component of the explanation of how one might respond to treating depression and anxiety, right? So then to say on this piece of paper, you know, this allele, this homozygous expression might lead to reduced response, is that truly applicable for this individual? Just the premise itself, does it even make sense to make a commentary like that? I don't know. Probably not. I think these are kind of overstatements, right? Same thing with the increased sensitivity commentary, right? Again, correlations. How sure are you? And trust me, if you did a little bit of digging in the literature that they're citing, very limited literature in terms of concreteness and certainty about these commentaries. So very loose associations, correlations are being put on these reports as if they are fact. And that is a problem, because then you give this to a clinician who doesn't really care about dissecting this and looking at the literature that supports this, or the limited support that it has. You give this to a layperson who is desperately seeking answers, and you give them these concrete statements. This is where things can become problematic, in my opinion, because then this report can almost be interpreted as dogma, right? As scripture, as this is the truth. This is what is going to unlock my recovery, my healing, my success, my respite, my relief, peace of mind. And gosh, to then try to explain to folks this is for guidance, and if anything, loose guidance, it becomes a challenge where this can become an obstacle sometimes to treatment. Okay. Let's move on. So this is what I was referring to earlier. Okay. This is some of the, those yellow and red columns. This is also what some of those columns are referring to, right? And if you look here, if you look at the first two findings, right, it says extensive normal metabolizer, basically saying, for drugs that go through those particular enzymes, not much you really need to be worried about. metabolism should be within that mean of the bell curve of the average person. Now, if you look at that third row where it says ultra rapid metabolizer, like that would be an interesting finding, right? This is where, if you are that outlier, right, and you are an ultra rapid metabolizer at a certain enzyme, and if a medication went through that enzyme, again, patient may have increased enzyme activity as compared to individuals with the normal phenotype, meaning serum levels might be lower than you would expect, potentially. And is that someone where you might need even higher than average doses in order to achieve similar blood levels or serum levels that one would expect in the average person? And I'll give you an anecdote about that in a little bit. Okay. So this, yes, guidance, want to be careful here, but I also want to give credit, right? There have been times, a few times in my career where I do feel maybe this might have made a difference. Okay. So let's give some anecdotes here, right? One anecdote is sometimes, it will say this person is an ultra slow metabolizer. Be careful, use with caution. Because they metabolize this drug so low, levels might be so high that you are putting them at increased risk of side effects. And there have been times where I've had that patient on the maximum dose and they tolerate it better than other folks where, the results say normal metabolizer, and I might have that person on a fractional pediatric dose and they're puking the first day I give them a dose, where this person who says they're an ultra slow metabolizer, be careful, use with caution, are on the maximum dose and not even flinching, right? So I know that was very general, but I'm just telling you, like, it happens all the time with these results where it even says that they're an outlier on one end of the spectrum and it really doesn't even play out that the way that these results depict it, right? But to be fair, right, I said I was going to be fair. I think I might have mentioned this in a previous episode when someone was asking about genetic testing like this. I did have an individual where, we tried, several different antidepressants, different categories. I did feel they did have the prototypical, quintessential MDD, for whatever that's worth, where they did tend to have an episodic style of depression that would come and go. They would have clear windows of achieving remission where they were not depressed. They can clearly define, they knew what it felt like to not be depressed persistently and pervasively. Said, okay, like this is someone where it is worthwhile. And also given the severity of their depression, it is worthwhile to use medications to supplement and complement therapy, right? Because again, my stance. I think SSRIs, SNRIs are just overprescribed, overutilized. We're misdiagnosing patients with types of depression that probably aren't going to respond to meds anyway, right? And using them for mild and moderate cases where I acquiesce, placebo probably is as effective. Or the other way to say it is meds. I'm not sure that these meds are really any more effective than placebo. But even in the midst of those criticisms, I do believe neutral, unbiased statisticians will also agree that severe MDD specifically, these meds do seem to have more effect than placebo, right? And so I do believe there is a role for prescription antidepressants to be used sparingly. And there was one case where GeneSight testing was useful where, I tried several different types of antidepressants in this individual. And interestingly, weren't getting many responses. And then, I decided to use an older antidepressant, a tricyclic antidepressant called nortriptyline. And nortriptyline is one of the few antidepressants where, again, I wouldn't say definitive guidance, but we have some correlative guidance on what your blood levels should be uh, for the average person to get a good effect for their depression. So I said, look, we've tried several things. Why don't we use one where we can actually check your unique blood level? It's not some fancy lab that has to be sent out to some exotic lab that'll take weeks to get results. Like we can get results within a few days. So we did that as kind of the next foray into their treatment, checked their nortriptyline level. And I was very surprised because it basically came back as non-detectable. And of course, I had to ask, are you sure you're taking this compliantly? And, without trying to judge or be accusatory. And they're like, yeah, I'm taking it compliantly. And I believe them. They were always a compliant patient. What reason would they have to not be compliant? They're always showing up for their visits. That's proof of some compliance. So I said, okay, well, let's increase the dose. And I said, maybe you're just kind of an outlier. Increased it, got another blood level. Again, basically almost a non-existent blood level, as if they were not taking any nortriptyline. So then, I said, let's get some GeneSight testing. We did the testing. Results came back that they were an ultra rapid metabolizer at the enzymes that are involved in the metabolism of nortriptyline. So interestingly, this was a case where what I was seeing clinically was matching up with the genetic testing, the liver enzyme profiling, everything lined up. We tried something else that did not go through that particular enzyme to avoid that ultra rapid metabolism, and we got a better response. Okay, so yes, to be fair, there has been a situation where this liver enzyme profiling has played out, ended up being helpful as a helpful tool. Now, I will say though, that's one or two cases in 14 years that I can confidently tell you that made a huge difference in treatment, because the other vast majority of cases where I've gotten these, like I said, either what we were doing clinically did not match up with what we were seeing here, where it says, they're a super rapid, metabolizer. You might need higher doses. We couldn't even get past the low doses. And I know metabolism and sensitivity are two separate concepts, but again, just interesting. And then same thing, like I said earlier, like super slow metabolizer, be cautious. And this person wouldn't even flinch when we're at the maximum doses, not even a single side effect, which was amazing and surprising, right? So now here's the other scenario, right? I have had patients who've come back where their liver enzyme profiling have just said like normal metabolism. It's weird, right? Because like having normal metabolism isn't necessarily a bad thing, but then from patients' perspective, you almost get this like disappointment. You almost get this disappointment from them because they're like, I was expecting there to be some kind of outlier finding, right? And when they say like the results say normal metabolism, and the vast majority of the antidepressants are, let's say, all in this green category, right? Use as directed. There's almost this interesting disappointment. They're like, well, so this basically says just try one of these and use as directed. And I go, yeah, that's what it says. And they go, well, what was the point of me getting this swab? And I go, I guess for more information. So again, I'm not trying to be overly cynical. I'm just portraying realistically. Sometimes that is what you end up getting, where there are no major mutations and abnormalities in these genetic variation, gene locations. There's no some stupendous outlier finding in your metabolism. And there's almost this interesting disappointment from the patient's perspective, right? So moving down in this report, they kind of break it down just for easy visuals. This is really everything we've already talked about, except here on these pages at the end, they're listing each medication one by one, just so you can see the particular enzymes that might affect it and the commentaries about subtypes of your liver enzymes that might affect the metabolism in one direction or the other. So this is just more a visually uh, easier to read kind of chart format of what we've already talked about verbally. Okay. All right. Let me see what else to kind of highlight here. Now what's missing here, because this is a little bit of an older sample, like I mentioned, is there are in the newer ones, there's also commentaries about whether you have genetic expression of having difficulty converting, folic acid. There are some commentaries about antipsychotics in particular. They've isolated some genetic variations from the CATIE trial, CATIE, which was a large study done on schizophrenia to show that maybe if you were in this subgroup of patients who had genetic patterns that might correlate to a better response to Zyprexa or olanzapine specifically for your psychotic symptoms. And they will let you know if you were in that subgroup that had similar genes to those who responded well to Zyprexa. So there's a couple other findings that probably should be on that report that I showed you, to be fair. So there are a few more things that are missing because that likely is a sample chart from several years ago versus kind of the more up-to-date reports from GeneSight. So in summary, here are the comments, right? Number one, this will not definitively tell an individual this is the best antidepressant for you. Okay. This is the best SSRI, SNRI for your depression, for your anxiety. Okay. I have seen a few different companies, not GeneSight in particular, but a few other companies that have additional commentaries in their reports that'll say, hey, there's genetic evidence that you have bipolar disorder, that you have ADHD, that you have clinical depression or major depressive disorder. And I've seen patients go on YouTube, right? And you'll see patients who will show their reports and say, see, I have no control. There's genetic proof that I have such and such disorder or disease. And that's where my eyebrows go up. And I say, that's interesting because there are no definitive genetic tests to diagnose these disorders. Researchers might argue with me, but there is none. Trust me, if there was one, the hospital medical industrial complex would be milking the hell out of that and profiting it, just like we do excessive MRIs and stents for hearts and knee replacements. Trust me, if there was a definitive way to tell you what you do or don't have, genetically speaking, from a mental health standpoint, oh yeah, we'd be profiting off of that. We'd be doing it like an assembly line right now. So I'm sorry. No, there is no definitive genetic markers to diagnose or rule out, these mental health disorders. So there isn't going to be a definitive conclusion about these meds are best for you. You do or don't have some specific disorder. So that's not what these are meant for. Again, to be fair, what it can tell you is there are certain liver enzyme profiles that could give us some guidance that you may be a more rapid metabolizer, slower metabolizer, ultra rapid metabolizer, average metabolizer. So that could give us some guidance, at least on some choices of meds. There may be, again, loose, very loose is my opinion, probably looser, like everything else in my opinion is less concrete than the metabolism commentaries. You saw that on that page, some correlation maybe about if you have polymorphisms in your serotonin transporter genes that might correlate with increased sensitivity to side effects, possibly. Okay. I will say more concretely, telling you if you have those variations in whether you can convert folic acid or not. But very loose. And then Last couple comments, there are folks who say, but look, if you go on their website, it says those who used GeneSight testing as part of their treatment with their prescriber had far better outcomes, you know, less financial burden, less side effect burden, et cetera, et cetera. I'm sorry. Biased studies, not large scale studies, not rigorous studies funded by GeneSight. Okay. Just like I said, I'm an equal opportunity criticizer. Just like I can criticize pharma research, it's industry biased, company run studies. What do you think the outcome is going to be? And trust me when I say these are not rigorously done studies. Okay. So that doesn't move the needle for me when patients say, well, look, on the website, it says their studies show that like there are better outcomes. Really? No, I don't think there's really solid evidence there are better outcomes when you use GeneSight when you don't. Okay. And last couple things here is when there's comments about this, about, you know, you may be more sensitive to this, you might respond better to this. This is all also still predicated on, was the diagnosis even accurate? Right. And I know I went on that soapbox about how MDD is overdiagnosed, but yeah, MDD is overdiagnosed. MDD is overdiagnosed. We're diagnosing it in people who have these more chronic, multi-year, 10-year-long episodes of depression. And I'm sorry, that's not what the conceptualization of MDD is about. MDD, when we're saying MDD in patients who've been depressed for 18 years straight due to trauma, due to chronic substance use. And I'm not saying that those disorders are exclusive then and you can't have you can't have acute bouts of MDD. I'm just saying oftentimes depression will come hand in hand with a lot of other disorders, yet we just kind of cling on to this terminology of MDD. And then this whole premise of using this to guide the use of SSRIs, I mean, it just falls apart. Because other than generalized anxiety disorder, panic disorder, MDD, the use of SSRIs is really off-label. And therapy needs to be the primary intervention in all the other cases. Therapy needs to be the primary intervention even in MDD and GAD, right? I'm just saying those are the few places where there's some semblance of modest and decent evidence of using SSRIs. Everywhere else, it really just falls apart. Yet we're using this, right? Assuming that the diagnosis itself was even accurate, right? Because if it's not MDD, if it's not GAD, and it's just more amorphous anxiety, amorphous panic, amorphous sadness, minus the metabolism commentaries, the rest of this is just like, what do you do with this? Okay. And then lastly, right, the concept of what Dennis was talking about. I do get a little concerned when folks, not just patients, but their loved ones will then almost latch on to this piece of paper, this report, and this becomes the absolute truth. This becomes dogma. This becomes their scripture. And sometimes it can become a hindrance to the treatment alliance and the rapport. For example, I've had patients where the patient themselves was open to suggestions. And I'm not like trying to be, I can be narcissistic. I'm not overly narcissistic in my opinion, but, you know, I don't try to buck it. I'm like, look, if I got like 13 SSRIs and SNRIs to choose from, and I'm not really wedded to any particular one per se, and you've never been on any, and you happen to have these test results, I'll roll with it. Why am I going to I'll use this to my advantage, and I'll try to steer away from the ones that say, hey, slow metabolizer might be more sensitive. Okay, then let's avoid that, because what's the difference? There is not one SSRI, SNRI that's superior than the other. There isn't. Okay. So yeah, I'll use this to, again, keywords. You've heard me say the word guidance. I'll use this for guidance. Okay. But Where it becomes problematic is someone who has maybe tried a few different things, so there's only a few options that they want to try, and then it'll say yellow, use with caution, red, potential big interaction, and they'll say, no, I'm not going to try it at all. Or their loved one says, absolutely not, that's unsafe. I'll say, look, this is, you see the words may, you see the word potential. This isn't fact. These are guidances, these are correlations. And man, sometimes it could be super hard to navigate that conversation and negotiate to say, look, we're not going to be irresponsible. We can be cautious. We can dose conservatively. We can start low. We'll take this into consideration. But from my experience, it doesn't always play out the way that these reports say. But we need to, let's see what happens, because you're interested in med intervention. Let's try it. It's reasonable in your situation. And sometimes you just get absolute no. And they unfortunately will sometimes box themselves into treatments that I don't really agree with. And then we are at an impasse, basically. Right. And the opposite of what I already mentioned to Dennis's comment earlier, I've had patients where things were relatively fine from a tolerability standpoint, response standpoint. They get this because they were just curious. They say, oh my God, it says that I shouldn't be using Lexapro, use it with caution, but I've been on it for 5 years. I say, well, is it working? Yeah, no, I'm getting a very good response. How are the side effects? Minimal to none. Then what's the issue? Well, this says now, and then this seed of anxiety and doubt has now been planted. For some people, they can move on and not pay attention, and others will just perseverate, ruminate, and then almost exacerbate their symptoms, because now this report is saying, ooh, you got to talk to your doctor. And, and of course, right, these companies will say, oh, no, like we said in the fine print, clinically correlate, have a conversation. But come on. Your business model is not based off the fine print there. Your business model is unlock the secrets to your success, right? To your healing, to your recovery. So it creates this kind of, dilemma, because people will interpret this as if this is absolute fact and dogma, right? So, but hopefully if you and your prescriber have a good rapport, you can, again, not ignore some of this additional information. You can incorporate it, but then use logical, rational, critical thinking to just incorporate it and not blindly follow it. That's my personal take. So at the end of the day, right, I'm not trying to steer you away from doing this per se, but if you ask me very bluntly, how much of an itch, how pressing is it for me to make sure that my patients get this? I'm going to say not that pressing. Okay. I don't see it as a high priority. I think if it can get more sophisticated, we actually understand pathophysiology, mechanisms better. We refine this, which to me is probably going to take another 5 to 10 years, if even, maybe even longer. Okay, then let's talk, and let's make it a little bit more integrated into our standard of care. But right now, current state, with how limited our understanding is of depression, anxiety, all these different things, mechanisms of action, how accurate our conceptualizations are of how these mechanisms help treat these disorders. My comment would be, if your insurance covers it, or you can really get this at a minimal out-of-pocket cost, sure, what the hell? I don't think it's truly harmful to go get it. It's non-invasive. You get a Q-tip swab, you get some additional information. You might be an outlier who has an outlier metabolism in one direction or the other. Maybe you get some insights on some genetic variation, like your folic acid conversion, etc. But if you don't have good insurance, or you have no insurance, and you're going to have to pay a pretty hefty sum out of your pocket for hundreds of dollars, and if hundreds of dollars is the difference between rent and putting food on the table and buying the necessities for you and your loved ones versus getting this test, I'd put this very low on the totem pole of priorities. Okay, so if you could read in between the lines, you can see how much of a necessity that I view this kind of testing is. Right now, I would just say, yeah, there's limited utility. Not saying it's worthless by any means. I just think it's overhyped, and I wouldn't go spend your hard-earned money unless you have disposable income and don't mind just kind of checking out of curiosity, or you're truly at a treatment impasse and hope that this might give you some insights. And most importantly, coverage is good, and hopefully you don't have a ton of out-of-pocket costs. So that's my take. And hopefully for those of you who've been emailing me, whether you're watching live now or watching on a recording, found it useful for me to walk through that report with you guys. So, all right. Well, I think there's only a few people left here on the live. So we'll open it up for Q&A just for a few minutes before I log off here. And thank you guys again for subscribing. I know I went on a hiatus and took off for spring break, so I appreciate your patience, and thank you for those who tuned in today. So yeah, so we'll open it up for a couple minutes. Otherwise, yeah, we'll go back to our usual slots Tuesdays and Saturday nights, 10:30 Central, 11:30 Eastern. And for those of you who are new here, please subscribe. Check out some of my evergreen content. Leave some comments. Let me know if there's other topics you want to make sure I cover in upcoming episodes. Otherwise, hope you guys are doing well. So, all right. Well, thank you guys for tuning in for today. And I will catch you guys at the next episode this Saturday, 10:30 Central, 11:30 Eastern. You guys have a good night. Thank you again. And I appreciate your support to all my subscribers. Have a good one, everybody.